Hello, everyone. This is Dr. Gorana. Welcome to episode 3 podcast Hair on Air. Today's guest is going to be talking to me from Brazil, and we're going to be talking about large FUE sessions, or how big can we go in our surgery. Today's guest of my podcast is Dr. Marcio Crisostomo from Fortaleza, Brazil. He is a plastic surgeon, my fellow plastic surgeon, and also hair restoration surgeon. To introduce him, he did 2 years of residency in general surgery, and then he had this amazing opportunity and honor to do 3 years of plastic surgery residency with the father of modern plastic surgery, Professor Ivo Pitangy, in Rio, in Brazil. He was a substitute professor of surgery at the Federal University of Ceará for 5 years, and he's a founder of Crisostomo Hair Institute in Fortaleza. He's a member of many hair transplant surgery societies and plastic surgery societies. He's a diplomat of American Board of Hair Restoration Surgery, and he recently has completed a post-graduation training in surgical leadership at Harvard University. I have really great pleasure to host today my friend from Brazil, Dr. Marcio Crisostomo. Marcio, welcome to Hair on Air. It's nice to see you.
Thank you, Gorana. It's a great pleasure to me. Thank you for your kind words.
No, I haven't started yet. I want to share how I heard of you and how we later met and became friends. When I started doing my FUE work, it was 13, 14 years ago. And a friend of mine, a Brazilian who you did your training with, told me, "Have you heard of untouched strip?" And I was in shock. I was like, "No, I don't know what it is." You have to go to visit my friend in Brazil and to learn from him how he does these large procedures. And even now, so many years later, I haven't visited you. You haven't taught me how you do it, so you're going to do it today during our podcast. Is that okay?
Absolutely. And you're invited to come here to Brazil, not to see surgeries, but of course, to have a wonderful time here.
Thank you. Thank you.
You and
I
Jack, of
hope
course.
we're going to make that happen. So, since I mentioned Professor Pitangy, how did you start doing hair since you had this opportunity to be trained by the greatest of us, the greatest of all plastic surgeons? How did you decide to switch to hair? Because I'm sure that that's not really a specialty of Professor. It wasn't his specialty of Professor Pitangy.
Yeah, it wasn't, but Professor Pitangy's service was a complete plastic surgery service. So we saw many aesthetic procedures, but of course, burns and hand and microsurgery. We did a rotation in many services, and one of surgeons in the staff, Dr. Henrique Radvansky, nephew of Professor Pitangy, he did a hair transplant job in Santa Casa in Rio. It's a very, very nice job in burn reconstructions in the scalp and sideburns and eyebrows, and of course in androgenetic alopecia. And I started to follow him in Santa Casa. When I finished my post-graduation, I did all plastic surgeries, but I realized that hair transplant surgery, I fell in love with this surgery, the procedure, and I realized that you need to do only hair if you want to do it well. It's very difficult to have a trained team if you do it occasionally. So I started to stop slowly my plastic surgery activities and surgeries, but I did plastic surgery for about 10 years. And then I left completely. When I did this, I felt like I'm betraying my amazing opportunity, as you said, to learn. I was seated in a place that another person could be there. And then I switched to hair transplant surgery. I talked to one of my wisest professor at Pitangy Center. And he said to me, because I felt I betrayed my specialty, like, okay, I had this amazing opportunity. Sorry?
I felt the same way.
Yeah, it's difficult to, but I thought, oh my God, I had this amazing opportunity to study with Dr. Pitangy, and now I'm moving completely to a different area. So I talked to this professor, the wisest one that I had in this Pitangy Center, and he said to me, you are absolutely right. Don't worry. You need to look at plastic surgery as an important step for you to move forward to the next step, that is hair transplant surgery. Go and do your best. And I realized that all the plastic surgery concepts that we have, I'm not saying that plastic surgeons are better than other specialties, but as we deal with aesthetic for so long, so we have this refinement, these concepts, you know, the details, and I bring it to my hair transplant practice. And of course, the style of doing the surgeries, because in plastic surgery, I used it to combine breast and tummy tuck and liposuction. So all these combinations, in order to get the best result, I bring this kind of concepts to hair transplant surgery. And this is my style until now.
Very nice. I think very often are plastic surgeons doing the best work in hair transplantation surgery, and that's not necessarily true. And I'm going to share with you and like to hear your opinion. I think the best work is the one who does them more surgeries. Like, for example, if you have a plastic surgeon who does one hair transplant a month, he's not going to be that good in hair transplantation. Do you agree? Comparing to, let's say, a dermatologist who does 3 or 4 procedures a week, he's going to be excellent in hair transplantation surgery. So I think it's the amount of cases that you do and that you improve your technique. Would you agree with that?
Absolutely. Frequency makes perfection. Practice makes perfection, of course. I think it's the same in sport. If you are a soccer player, for example, and if you play with your family on Sundays, it's one thing. You may have talent, but it's not enough. If you do it daily, every day, if you breathe this every day from the moment you wake up until the moment you go to bed, so practice makes perfection. It's not the specialty. It's practice. Of course, in plastic surgery, I feel that this aesthetic details and concepts that we can bring into the specialty. If you move to hair transplant, then you can benefit with this and benefit the patients.
Yes. I laughed for a moment because you said like in sport, and for you in Brazil, soccer is sport, right? That's the first comparison that comes to your mind.
Oh yeah, of course.
So anyway, tell me, how did you start? So you were trained in FUE, and then how did you start doing FUE, the new technique?
Yeah, okay. I was trained in FUE only, in Pitangy service, and then I started with FUE, and my practice grew when I visited Dr. Carlos Wibel from Porto Alegre, Brazil. He's one of the pioneers in our field. And I could observe his style, and I got more results. Then I visited Dr. Cândido Muricy. He's one of the fathers of hair transplant in Brazil. And I saw mega sessions at that time, like 3,000 grafts in FUE. And I said, oh, I want my team like this. And I was very happy. But, however, for advanced baldness, patients always want more grafts.
Yes.
And I realized that FUE has a limit, elasticity. If you cross some limits, you have complications. Hair transplant surgery, if you stay inside the limits, fly low below the radar of complications, I like to say, you barely have complications. But if you cross the limits, you may have some complications. So in order to have more grafts, I started to combine few amounts of FUE grafts after strip surgeries. My FUE procedures at that time, 2007, 2008, was not big. I was doing FUE just for scars, in small cases, when patients demanded, because patients FUE was not so popular at that time, especially in Brazil. Brazil was very delayed to accept FUE as a nice technique. And then I visited a colleague in 2010. I was doing combinations already, but then I visited a colleague and I could show larger sessions of FUE, but not so large, like 2,000 grafts at that time. And I realized that we could safely combine both. So I started FUE combining with strip, not as FUE only procedures. That's how I started in FUE.
So how today, what is the large, how do you perform the large session? For example, you have a patient who comes with the advanced baldness. What is your recommendation? Assuming he has a good donor area, he has a good density in the donor area, what is your approach? Because I know I texted you today and you said you did over 5,000 graft procedure, which is a high number of grafts to transplant in one day. How do you approach these patients?
Okay, I still do FUT and FUE. I'm not one technique practice. And I usually educate the patient in all techniques, all options, if I feel that all options can be good for him. For example, if he comes with a shaved hair in the lateral side, of course, I don't talk about FUT with this guy. But if he has like long hair and style, and I said, hey, listen, he wants more discretion in the post-operative period, like politics. I have many politics as clients. So I say, hey, we can do only a strip removal, and then your hair will cover the scar, and then you take away 1 week, and that's it. So they want absolutely secret around these procedures. So I recommend FUT. But when we talk about larger sessions or advanced baldness, let's say that advanced baldness is a class 5, 5A, 6, which means frontal area and crown area.
Right.
Okay. In my opinion, if we try to treat the two areas with a few amount of grafts, we'll have like not a good density patient, right. Unhappy patients. So, and as I did a lot of combinations before, like for more than 10 years, so I'm used to have these large sessions, 5,000 grafts, 6,000 grafts is my daily practice. It's not like, oh yes, today we did this session. It's our daily practice since the combinations. Then patients started to demand more and more FUE. Hi doc, I don't want a linear scar. Hi doc, I don't want a linear scar. For you to have an idea, 4 years ago, 63% of my procedures involve FUT.
63
or FUT alone. 4 years ago, 63%.
Okay.
Now, 86% of my procedures, surgical procedures, are FUE.
Wow.
So I didn't move completely, but patients are demanding more and more. I don't know if in this pandemic, as a lot of patients are in homework, even lawyers and businessmen and
doctors, they have more time.
They'd say, "Hey doc, you can shave my head," but usually they don't want to shave. So I believe that if you master all techniques, you can prescribe the better treatment. But talking about larger sessions, your question, if he has a long hair, I said, "Hey, I have the combo procedure and FUE mega sessions," and I explained the difference between them. And nowadays, most of patients want FUE. So my FUE, my larger session FUE was around 4,000 grafts 2 years ago.
Okay.
But then I started to push more and to divide the session in 2 consecutive days. So this surgery that I did today, that ended more than 5,500 grafts, was not done in 1 day. I started yesterday. The patient slept here in our hospital, and today he came back to the surgical room. It's much more comfortable for the patient and for the team. So that's how I managed to achieve larger number of grafts in FUE.
So this was all FUE only. This is not a combination of the two.
FUE only.
The FUE only. Okay. So my question. Yeah. Go ahead. Go ahead. So
And I must say that it's not for everybody, for every patient. Because every patient, if you post this in Instagram or internet, a lot of patients come and say, hey doc, I would like to have 5,000 grafts. It's not like this. You must have the proper conditions. Good donor, the evolution of the family history, a lot of concepts, a lot of questions to perform a surgery like this.
it's not as simple as people think it is. So the main concern in these large sessions is not to cause depletion of donor area. So there is no visible traces, there is no bad scarring, and that's why we as surgeons are told, oh, don't do more than 3,000 grafts, you're gonna cause bad scarring and it's gonna be visible. So how do you manage? Is it the appropriate candidate? That's to start with. But then there is probably some secret, like small punch type of the device, and just how you spread out the harvesting throughout the entire area. What's your technique to achieve that?
What I do is we use smaller punches. 0.8 is our routine punch.
Do you have a favorite machine that you use, device?
It's a simple rotation machine. It's not any complicated machine, because I feel there are other parameters like the surgeon hand that make more difference than some stuff in the machine. I don't use, for example, the trumpet punch. I know you like. I saw you in ISAP's meeting. You like the Devoir machine. It's very nice. If you want to have like zero transaction, there is no zero transaction, but I'm talking about the whole follicle. So since I started FUE,
there is 1% transaction with the Devoir.
I have much more partial transaction than this, because since I started FUE, I discussed this many times with Jose Lorenzo and other colleagues, evaluating the patient when they come back 1 year, 2 years later for a second procedure. I could see that many hairs are growing into the scars, the punctiform scars. So, in my opinion, if you excise the whole follicular units, like 3 hairs, you excise 3 hairs, great. You have a great yield. But in the donor area, you have this white spot. Very teeny, but you have this white spot. And you can't harvest beside this spot. Okay? In a second procedure.
Correct.
I realized, I call this the stain concept. I wrote this article but never published, because I want to prove this like with an experimentation, and I didn't prove this. But I feel when I see this in my daily practice, that in partial transaction, of course, I'm not going into details like the level of transaction, but many partially transected grafts, I see clearly when I do dermoscopy in the secondary patients. They grow through the scar.
The scar. Yes.
So if you have little bit more partial transaction that doesn't lower your level of hair per graft ratio. Okay, if you have like more than 2.2 hair per graft ratio, and have more partial transaction, you camouflage more your donor area.
Yes.
If you excise like with trumpet punch, that you have less transaction, and you excise all the grafts, great, you have a ratio of hair per grafts higher, but the donor area suffer a little bit. So in order to perform larger procedures, I like to have partial transaction. I know that what I'm saying is not a consensus. Most colleagues said, oh, crazy, no, if you have transaction, you are damaging hair. But I see it growing back. And I like to have partial transaction and to spread it through all the donor area. Don't concentrate just in the middle.
Yes, I know when you started explaining the transaction, I know you're going to talk about this. And actually, I also saw Jose Lorenzo a couple of years ago. He was doing large sessions with a similar approach, that you cause in vivo partial transection, basically. So you have remaining follicle that's going to go through.
Yeah.
So splitting, correct. But then you are the other thing you're getting lower ratio of hairs per graft. How do you then manage to create good density? Because you mostly have single, twos, and I guess some 3 grafts from extracting that way. Do you do the dense packing in the front to achieve the density?
Yeah, dense packing in the front, then average density in the mid-scalp. In fact, we don't have a lot of singles. In order to have singles, to make the entire hairline, I need to trim it under under microscope. It's not so easy to have a lot of singles in FUE to make a perfect hairline. So I don't have a lot of singles, most twos and threes. And I think in general, patients are enjoying and coming back. And I have this balance between the results and saving donor area. If you are too good in extraction, donor area suffer a little bit. So you need to have less grafts. And then there is a math behind it. Like, okay, if you have like 5,000 grafts of two hair grafts, 2 hair per graft, it's 10,000 grafts, I'm just saying. And if you have 3,000 grafts,
10,000
3 hair
hairs
per graft, so you have 9,000 hairs, the same thing. So,
right.
But in my opinion, this when I have this complete white spot, when I come back for a second pass, I can't harvest beside.
No.
But if I have a white spot with a hair in the middle, if
growing,
it's only one hair, I can harvest beside, and that's fine.
Right.
So I always try to think around a long-term master plan. You know. How can I approach this guy in 2 years, in 5 years? Is he gonna become like class 6, class 7? As I do this kind of combinations, large sessions, so a large percentage of my clients, my patients, are like or reparative cases or very advanced baldness. You know, they come and say, "Hey doc, I did 3 surgeries, I have this crown, and how you're going to do this?" So as I see a lot of repair cases, so it seems that I'm aggressive with large sessions, but I'm very conservative. In fact, like I'm afraid, like saying, "Oh my God, that is a perfect candidate for this." But in younger patients that demand a very low hairline, that is very common today. "Hey doc, I would like these and temporal points in every patient." I'm very conservative with this.
Right. So yeah, we always keep in mind that hair loss is progressive, that we have to think how the patient is going to look in 10 years from now, and it's not short-term solution that we have to offer them. And do you know what's your largest hair transplantation that you've done? How many grafts?
My larger hair transplantation or FUE transplantation?
Let's say FUE.
My larger transplantation? Yeah, let me tell you one thing. There was a time that I tried to cross some limits. It's not a run, but I would like to have the ideal patient to have a lot of grafts. Like, oh my God, when I did the first 5,000, then 6,000 grafts, then 7,000 grafts in 2 consecutive days. I said, oh my God, this is a very big surgery. And I had this patient that I did more than 8,000 grafts. A very good donor. Only the strip was almost 5,000 grafts, because the strip was very nice. And then I pushed the FUE, good. But the result was not so good. I think I had a little bit of poor growth, you know? So my ideal patient it's not about the largest amount of grafts that you can transplant. When I do, for example, occasionally in special patients, I have more than 7,000 grafts. Occasionally. More than 6,000 is usual for me in combos, and more than 5,000 in FUE or 4,600. But what I do is I don't dense pack too much, because if you dense pack in all this area, you kind of have poor growth, especially here in the mid scalp, the frontal forelock.
Right.
So I don't like to say I can get 7,000 grafts because I don't feel it's the best for the patient, because the growth rate is not so good with so many grafts in a smaller area.
Right. We have always the issue that I have in my practice is patients see those photos before and after on internet, and they see like class 7 male pattern baldness, and then the picture after is like full head of hair, and it's in reality it's not like that. It's so challenging because we're limited with the supply that we can basically transplant. So surgically, how do you maintain efficiency in such big cases? Because we know and our patients know that the grafts cannot be outside of the body for the long time and everything. So how do you maintain this surgery efficient? And it's also not comfortable for a patient. And I understand you split in 2 days. I do too for larger procedures, but I don't do as big cases as you do. How do you maintain efficiency through the day? Because it was 4 p.m. and you were done with your case today. So I want to know how you're free to go after 4 p.m. after you finish your case.
Yeah, what I do in my practice, I don't say that I think this is better than other practices. Just I'm used it. I learned this way and I'm doing this. I do stick and place here, most of my grafts. So I implant every single graft. But I don't harvest every single graft. You know,
Okay.
It may be shocking for you because I know that you probably harvest all your grafts, do pre-made incisions, and have your technicians or your assistants, doctors, whatever.
No, I still plant my cases. I like
you harvest everything and plant everything.
I know.
For larger sessions, it's not good, because if I harvest everything. At the beginning it was like this, I harvest everything and implant everything, but I feel that when I was like doing the hairline, temporal points, a very delicate part of the surgery, after harvesting 2,000-3,000 grafts, I was not like, so I have doctors, yeah.
I want to interrupt you because I fully agree with you, because we are tired after harvesting 3,000 grafts. It's such tiring procedure. And then you have to focus to make recipient sites, which is the key element of the procedure, and you are tired. So I think surgeon, it also impacts the creativity in us, because you don't get that attentive to details if you're tired. So it is very, very tiring, and I think you're sparing yourself from that tiredness that you can apply then when you're creating hairlines and doing other work. That I agree with.
What I learned with my Professor Pitangy, he always said you must have a doctor assisting you better than you, doing better than you do. So I have assistants since the beginning. I have now 2 assistants, but I had like 3 or 4 in the past. And I have an assistant that harvests FUE better than I do.
Yep.
At the beginning, I did everything. Then she started to harvest with me. Then I said, harvest a little bit while I'm rest. So I stopped from a while. I think that donor area management is crucial for the success of hair transplantation. It's what is going you grafts for you to work, is how you leave the donor area appearance later and years later to come back and reassess the donor area again. But I think the most important is the understanding of the donor area. It's the vision and the programming, like here we are not going to harvest a lot from here, or more density here in the back, or not here in the nape, whatever. So I plan the donor area completely. I harvest, but I don't harvest everything.
Yeah.
Most of harvesting FUE is from the doctors that assist me, and I prefer this way. And I tell this to the patient, hey, listen, the first part of the surgery is more mechanical. It's a doctor procedure, but it's more mechanical. And once it's understood, I prefer to save my energy, to create your hairline, to create your temporal points, to decide what is best. For example, at the end of the surgery, today I was close to the crown, and I said, oh my, 400 grafts more, I could go back, but I decided to come back to the front and spread these 400 grafts to create more irregularities and density in the front. So this decision is very important. For your mind must be very sharp and your focus for the hairline. So I prefer to save my energy for this. That's how I manage. I don't harvest everything. But I plant everything.
I'm gonna take that advice from you, because I've seen in my practice that I get tired after 2 hours of extractions. You're tired. Your eyes are tired, and I also want to mention that in the past, how we could tell that someone had hair transplant. Okay, we would look, in the creation of the natural looking hairline, if the single hairs are used in transitions and everything. But now I take a look at that, and then I go back to see what is done to the donor area, how is harvested, how is there scarring, is there visible traces? Because doctors do not take that as important. They say, okay, let's harvest, and then they create windows, and I call them barcodes, because they deplete a small area with harvesting, which is not the way to go. And now I'm glad I'm talking to you, who managed to do these mega sessions with FUE without depleting. And since this is also a YouTube video, we will show some of your donor areas just so patients can see what we were talking about.
But that's one thing that I want to say. It's not that we don't deplete any patient. There's sometimes patients come and say, "Hey doc, when I shave more in the temples here, especially in these areas, sometimes you see that oh my God, I harvest a little bit more here and there." It happens, of course.
Yep.
And one more concept that you told. And these larger sessions, what I think it's sometimes we cross some safety limits. And I say that Dr. Robert True is a very experienced surgeon from New York, of course, and he has this concept of safe zone. The safe zone for patients is the area that is safe, probably safe, because part of these hairs, I believe, will fall with the patient's lifetime, even in the safe zone. It's easy. You can see this thinning or even falling in this area, but the most safe zone. And there is another area around it that is not safe, but it's not completely unsafe. Dr. True said it is the transition zone. So in the past, when we had only strip, you could stay only inside the safe zone, because it's one strip, another strip, and that's it, you are inside the safe zone. But with FUE, you spread more. So we clearly cross the old style safe zone, and the anatomy doesn't change. It's the same safe zone, unsafe zone. But now we have this transition zone. Dr. True talked a lot about this, and I believe this. So some patients may, in some larger cases, we may cross some limits. Sometimes you can't see clearly. If it's a class 6, you see the drawing. But if it's mid-30s, patient could have more falling in this area, and you may harvest from outside. And maybe 10 years later, some of the hairs that you harvest may fall. But thinking about this and not defending harvesting outside safe zones, I think it's a mistake. But if it happens, it's not the worst thing that's going to happen, because if you cross like 10% of your surgery in this uncertain zone, maybe in 10, 15 years, maybe patient can lose 10% of the result, and the thinning scars of FUE will not appear like a linear scar outside the safe zone. So it's not a disaster. And I think in plastic surgery, we see this. When you do a facelifting, it's not forever. Patient can enjoy that rejuvenation for 5 years maybe, but it's not lasting 15 years. So if you have a pleasant result for some time, longer time, it's kind of acceptable to cross a little bit the safe zone. It's very controversial what I'm talking. I'm talking it to you, but
you're talking to me and probably a million other people who would wind up listening to podcasts. So everyone is going to hear about that.
That's what I believe. That's what I really believe. And I really believe that someone that does larger sessions of FUE, that is very common nowadays, and say that it's completely inside the safe zone, I don't believe so. We are always in the edges. That's why, if I have the opportunity to choose, if it's the ideal patient, I do prefer combo procedures, strip and FUE combined to have more grafts. I think patient thinks, oh, hey doc, I have this linear scar, it's much more aggressive. It's not aggressive because when we do a combo procedure, the combination, you don't do a strip like very tight. You do a normal strip, long but closer with no tension, so you get good scar. In the FUE around it, you can reduce the area, not to spread too much to the edges, because you have like 3,500 grafts from strip. It's a normal strip. It's not a very unusual strip. Then if you add like 1,800 grafts FUE, it's not a very big session. So you can have these two nice procedures, more than 5,000 grafts, and stay inside the safe zone. If you need the same amount of grafts only with FUE, you need to cross some limits, or in the edges of safe zone, or in some density in some cases. You may have some complications like a little bit of shock loss and delayed regrowth in certain areas because of the amount of extractions. So if I have the opportunity, I still prefer to combine.
That's always, I guess patient always ask you, doc, what would you do? And it's fair that you say what you would do rather than one approach rather than the other. But I want to mention, since you mentioned that concept of safe and unsafe zone, when we harvest the transition zone, when we harvest from such large zone, and that's the concept that Dr. True introduced, you get two types of grafts. Let's say safe grafts and not so safe grafts. And you have two options how to use them. You can use them combined and at first have great density everywhere. That slowly with time is probably gonna become a little thinner because those not safe grafts are gonna fall out. Or other option is to put those grafts from the transition zone on a side and plant them such as they're gonna mimic possible hair loss in the future. In other words, they're gonna fall out as a receding hairline. And these are two options that Dr. True introduced, how to possibly use those grafts that are not coming from the safe zone. Because now we know and we assume that like grafts from the nape of the neck are not safe. Many patients ask to get those removed, but they're not essentially safe grafts, and patients need to know that. And maybe their doctors are not telling them that, but we are, because we know that. Yeah. So since we're sort of on the clock right now, this is such a wonderful talk, Marcio. I really learned a lot, and I'm sure that our listeners and watchers have learned a lot. But since you've been in this field for so long and advancing the field, what do you think, what's the future of hair transplantation? When you're like thinking about that, what do you see that can get better? Are we going to go full robotic? Where do you see that we can improve efficiency in our work? What do you see that's going to happen in next, let's say, 10 years with hair transplantation?
In 10 years, I don't think robotics will have a great evolution. I think the robot is a very nice machine. I think it does more than I would expect it to do, but not like the hand. It's not like Da Vinci in urological surgery.
No.
So I don't think robotic is the future. I think more and more advancement in our materials and technology, thinner steel punches so you may damage less and less the donor area. I think we have two very good options, FUE and FUT. So as patients are demanding only FUE, I think probably in a shorter period of time, like 2-3 years, some complications of FUE may appear, and I think if the surgeon can offer FUT and FUE, it's better, and learn this, it's better, because there is the ideal patient for each technique. Of course, FUE is much more common nowadays, there is no question about this. I think the future will be around the regenerative medicine. I think the research is very slow, the results are very slow. I'm hearing about cloning and stem cells for so long, and some presentations seem the same, like, hey, some centers in Japan and Spain, but I think this is the future. In 10 years, maybe more regenerative medicine, prevention in our field. And the surgical technique is more understanding of these doubt points, like what's the safe and unsafe zone, and more knowledge for the patients, the importance of clinical treatments associated with surgery, and that the surgery is not a miracle, and I think more and more education. I think this is the future. I think we are very mature specialty.
We are, and actually the goal of this podcast is to educate patients, to hear from experts from around the world what we are doing and what is realistic for them to expect from us. And thank you for your time today. I know you were doing the surgery and you're going to lecture later on in a webinar. But thank you so much for your time today. And I'm looking forward to seeing you soon in person, I hope.
Yeah, me too. Our personal meetings where we met in the Bahamas and Montenegro and many others. I miss so much our personal in-person meetings that I can't wait to see each other and our friends safely.
Safely, correct.
Yeah.
Stay safe, Marcio, and thank you for today and for participating in our podcast.
It's a great pleasure. Say hello to Jeff and the babies.
I will.
Thank you, Gorana.
Thank you, Marcio. See you.
Thank you.